Good afternoon, everyone. This is the February meeting of the Plan, Design and Expenditure Committee of the Universal Health Plan Governance Board. I'm Helen Belanca, the interim turning into permanent chair of this committee, and we are just still letting people in. So give us another minute and we'll get started. Okay, how are we doing? We good? Is it everyone in as well?
Yep, everyone is in. I'm waiting for one more for quorum, but we can go ahead and get started if you'd like.
Oh, there's Chun Wei. Great, perfect timing.
Okay. Great. Welcome everyone to the February meeting of Plan, Design, and Expenditure. Let's get started with a roll call.
Excellent. Helen Belanca.
Here.
Chun Wei Chi.
Yep.
Thank you. Peter Addy.
I'm here.
Thank you. Gabe Endine.
That's me.
Betsy Boyd Flynn.
I'm here.
Mike Durbin is unavailable today. Rob Fizzette. I don't see Rob. Tony German.
Good afternoon, present.
Thank you. Eve Gray. Don't see Eve. Rosemary Hemmings. Don't see Rosemary. Julian Horner will be arriving a little bit late today. Max Kaiser is unavailable today. Jim McGee.
Here.
Thank you. Peter Merritt.
I'm here.
Thank you. Angela McKallick. Don't see Angela. And Jamie Osborne.
Present.
Thank you.
Great. So just confirming that is a quorum, right, Isabel?
Yes, that's quorum.
Okay. Excellent. Well, thank you all for coming today. Quick agenda review. As always, Mimi's going to start us off with some meeting follow-up and updates from our other committees and the board. Today, we have a couple of things to consider. One is a behavioral health proposal. We already did the bulk of this at our last meeting, if you recall, and we had a couple of questions about the funding strategy that we wanted to tie up that loose end before we officially brought it to the board. So that final proposal will come to the committee for a vote today. And just as a side note, Isabel and Mimi, I don't see it in the meeting materials. Was it posted and I missed it?
It was posted with the previous meeting, but we can include that link.
Right, but we've updated the funding portion of it, or no?
Yeah, there are some small updates. So Isabel, I'll make sure that you've got that version.
Yeah, and let's if we can post it, or I know we can't post it to the website, but if we can make it available to committee members, or we can show it on the screen or something, because I want to do the updated version of that. And then Lee's going to go over some additional information about prescription drugs. This is a major area of costs, of course, in our healthcare system, and there are some cost savings opportunities there. So we're going to dive a little bit deeper into prescription medications. And then after our break, a more broad conversation about cost containment strategies, and that should wrap up the meeting. So with that, I will hand it over to Mimi.
All right. Thank you, Chair Blanca. So, good afternoon, everyone. This is Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. So, wanted to follow up on a couple of items from last month's meeting. So, the first one, the behavioral health proposal. So, you heard about that, and Lee had the opportunity to meet with Eve Gray and also with Cheryl Ramirez to really do some in-depth work around the behavioral health. So I think that's going to be really exciting to hear about. The specialty care payment proposal that we all talked about the last month, revisions that were suggested by this committee were made, and then the proposal was approved at the January 15th board meeting. So thank you all so much for your input and your work into that. We had talked about cost containment. So we are going to be discussing cost containment today. One thing I want to say is that, I mean, as you all know, there are so many different facets to cost containment within healthcare. So certainly discussion today will hit some of the points, absolutely not all of them. So this is really going to be kind of an ongoing discussion. So even though there may be some presumably cost containment recommendations that you all want to put forth to the board, it's certainly not the end of them. So I just thought I'd toss that out there. And then we will talk a little bit about workforce in Oregon in the month of March. So that's what I have from follow-up. Any questions about that? I'm not seeing any hands, so we'll go on to the next. All right, committee and board updates. So things are definitely getting more busy at the board level. At the January meeting, there was an in-depth review of the revenue proposal, and I would say that that is moving along very well. And as I mentioned, the specialty care payment proposal was also approved. At this upcoming meeting in February, so the last meeting was really all about revenue, and this upcoming meeting is really about expenditures. So we're going to go over, just as you all have kind of had that in-depth look at the Milliman report, and the board has had some of that, but we're really going to pull some things out and look at expenditures and also potential ways in which some of those expenditures might be modified. Also, I'm excited to say that Dr. Chun-Wei Chi is going to present at the board meeting. He's been at a couple of international meetings about unified healthcare efforts. So if people get the chance, I recommend highly that you get to tune into that. There, of course, at the board, there will be other updates as well. Next, our Community Engagement and Communications Committee folks have been doing tremendous work. They had put a pause on some of their meetings just because there was not the need, because most of their deliverables had been met. However, there was an update meeting in January, and the CECC committee has made a couple of changes to enhance the accessibility of information around the Universal Health Plan. So one of those things that they agreed upon is that their meetings, which the regular meetings are going to restart in March, will actually sort of span the regular workday, and that they will start at 4 and go into 6:30 p.m., which I think is really very gracious of all of the committee members and of our chairs. So that's the hope, that more people might be able to attend, folks who are not able to attend during regular work hours. There will also be an extended time if people would like to provide public comment. We know that sometimes it is a shortened amount of time. So the purpose of the extension of the meeting into the other hours is to allow for more time for public comment. It won't be the back and forth. It will still be people presenting their thoughts and the committee taking them back, but I think that's going to be also very beneficial. And then lastly, what's really happening with the help of all the committee chairs, and also especially our CECC chairs and our consultants, both Diana Bianco and Patty Wentz, are really working on putting forth these targeted engagement meetings. There's a tremendous amount of thought going into it, defining the groups that have been requested, defining who might be in the groups, and just to make it clear that all of that information is really coming not, or the decisions are not happening with the consultants. The decisions are really happening from the committee chairs and the board chairs, all from feedback that has come from the committees as well and the participants. So that's some exciting work. The plan is for those meetings to happen in March. The other thing that's happening is that committee chairs are working with staff and other folks to develop some specific questions for those groups that are being directly engaged with. So I think we've talked about this before, but some of the groups include, of course, provider groups, potentially insurance groups, if they are willing to communicate. And then there are a lot more than that, CBOs, small businesses, large businesses, et cetera. So that's it for that one. Next for our always prolific operations committee, they've completed their part of what they would like to do about the enrollment proposal and a subrogation proposal. Those are going to go in front of the board at this upcoming meeting and have really just started the discussions around information technology strategy for a universal health plan. And that will definitely not be completed by the end of the operations committee, but will flow over into the transition committee. Finance and revenue, as I mentioned, they've really been working on their the revenue plan. That's almost all wrapped up. What's happening now is there's a revision of the revenue target. So working with Milliman and Echo Northwest, and they are going to kind of bring things together into the year of 2026 and look at the proposed revenue plan from that standpoint. They're also working on a strategy for developing sufficient or having access to sufficient reserves to start up the universal health plan. Gabe, I see your hands up.
Yeah, thanks, Mimi. I think I just heard you say that the finance committee has had a revision in their revenue target. Can you expand on that a little bit more?
You bet. So as you know, this process of the whole way the universal health plan thing was going about was a little bit a parallel process where like, well, this committee was talking about benefits and eligibility, but the revenue team was trying to develop a plan. So develop a plan, they had to have a number. The number they have used as a target was developed from the Optimus report from the Joint Task Force. So that was 2019 data and the year was 2022. So that was all of these assumptions by Optimus. Now, as you know, Milliman has been involved and has done a tremendous amount of work updating that information using the all payer, all claims data, so Oregon specific data. So they have this a new estimate, and I will definitely say this is an estimate. It doesn't mean that that is exactly what will be chosen by the board or by the committees, but that estimate is different than the Optimus estimate, even bringing it forward. So they're really now trying to sort of meet in the middle of deciding, all right, for this point. So I'll just use that I don't want to say that wrong number. And I see Richard's on here. I think the revenue replacement target was around, I want to say like 16 billion. That was the number that was chosen, and that would have been in 2022 dollars. So what is happening now with this more specific and up-to-date data is that now that's going to be brought forward to 2026. So that was such a long-winded answer. I apologize. Did that help?
A little bit. Thanks, Mimi. I mean, my recollection from our last meeting was that Milliman's got multiple different estimates now, depending on whether we're including Medicare or excluding Medicare. Can you help me? Since
Yeah,
we're not having joint meetings with finance now, I'm curious what they're being told and which of those estimates they're trying to work
Yeah.
through.
yeah.
Yeah.
Can I take it, Mimi? Okay, so Milliman has given us a bunch of different bits of information. So their job is to try to predict expenditures, and the year that we're aiming at is 2026. The implementation target year is 2032, but it's going to be more accurate to get numbers for both revenue and expenditures if we use 2026 data. So we're trying to get revenue and expenditures both in the year 2026 so that we can compare what we anticipate expenditures will be and then try to get the revenue strategy to match that, right? We have to see if we can pay for it. So that's the first goal, is get everybody in the same year. You're correct that Milliman has given us a bunch of different estimates at our request. So as you can imagine, their work to predict healthcare expenditures is really difficult. And they've given us a low range and a high range. And then sort of like if you cut that down the middle, here's kind of like one number that you can focus on. That is their estimate for 2026 and then projected forward to 2032. That's the main thing that they've done for us. In addition to that, we've asked them to break out a couple of little pockets so that we have the option as a board to think about different ways that we could modify our expenditure predictions in order to best meet our needs. So for instance, we might phase in markets differently. The way we phase in Medicaid is going to be different than the way we phase in Medicare, and it's going to be different than the way we phase in the commercial market and the uninsured market, right? And so we might need to think about a phase-in strategy and an approach to doing this work that considers different markets differently and how we bring them in to the Universal Health Plan. So we asked them to tell us like what portion of the expenditures is attributable to Medicare, right? And it's easy for us with state data to figure out the portion that's attributable to Medicaid. So we just want buckets of data so that we have options as a board to kind of think through how things might be phased in or brought on differently. And so they've done that for us and for us to be able to use that as a tool. Does that help?
That partially helps. Thanks, Helen. But then which of those is revenue trying to work toward, or are they trying to develop proposals for each of those?
No, they're trying to work toward the main expenditure target for 2026.
Which includes Medicare?
Oh, of course. Yes, absolutely. It's the Universal Health Plan, unified financing strategy, everybody in.
Okay.
That's what they're aiming for. And they have a range, a low range and a high range of that estimate and sort of a middle of the road. But no, that is the target that they're looking for. It's just that, as Mimi said previously, what they were working off of is an estimate done by Optimus.
Right.
It was a different, right. And so they used a different data set. And so now they're just adjusting their target so that they meet, Milliman's new estimate of expenditures. But yes, everybody in 100%. This is a universal with
and that 2026 estimate. Does that include any projections for administrative cost savings?
Right. So this is really hard. This is a giant project, and a little bit of the way we've split things up is artificial in the sense of course, you need to consider all of the different pieces. What Milliman's estimates for this committee did, and the ones that finance revenues primarily focuses on, is actual medical expenditures, the money used to pay for healthcare, period, with no administrative costs considered. There's a different team at Milliman, not Fritz and Ken, who've been working with us, but a different team at Milliman that has done some work on what the estimated cost of administering the plan would be. And that bucket of expenses is thought of separately. But then when we look at the whole cost, like the whole enchilada of what this would cost, you see expenditures, which is like paying for medical care. And then there's a line for administrative costs that was developed through a different strategy. And that's the cost for the public corporation to administer the plan. It doesn't include administrative costs at the provider level. So those are wrapped in because that's part of how medical care is paid for now, that those costs are wrapped in currently to what like paying for medical care would be. And yes, we've gotten tons of feedback about this. We completely hear everybody about it's going to be different under Universal Health Plan. Administrative costs are going to be different. The cost to providers are going to be different. Yes. We understand that. But Milliman can only work with the data that they have and tell us, like, if things stayed the same, what would it cost to pay for healthcare in 2026 and then in 2032? That's the only data they have. They're going to use data and make their best actuarial estimate. We as a board have the very difficult task of then taking that number and trying to predict, okay, that's what it would cost. We know that things will be different under a Universal Health Plan. It is really hard to estimate what that looks like. We're going to do our best. We're going to get some opinions on that. We're going to take Milliman's number and qualify it, right? Like, we don't want total administrative costs to be more than 4 or 5%. That's kind of our target. And we know that, you know, the cost to providers is going to be different, but those numbers are nobody's ever done this before, right? So we don't have anything to base that on other than our best guess, and we'll certainly try to do that, but that's sort of like the next step.
Thanks, Helen.
All right. That's such a great question, Gabe. And I would say too, you know, not that part of that work again, and I've talked about this with other folks as well, is that there's sort of the ongoing work that will be happening until the report is finalized, and certainly using resources such as some of our consultant work and then some academic resources about sort of, so although Helen said best guess, obviously we're not really guessing, but we're taking in kind of information from all of these different sources. Although some of it is true, I think, especially with information systems and the amount of savings that may be possible through that is a little bit more, even more challenging than other things had been. But thank you for bringing that up, and I'm glad. I think that was a great explanation, Helen. I think people really appreciated that. So having said that, moving on, the transition committee, I'm excited to say, folks who are graciously agreed to help serve on the transition committee will have a kickoff meeting in March at the board level. At the board meeting, and this will also be sent out to the transition committee members, is a draft of a charter. Essentially, it is to work on a transition plan, and also kind of there may be some of these revisions that will then be put forth to the board. So the final decisions, again, will lay at the board level, but that's what the transition committee will be working on. All right. And I think, unless there's any other questions, I think that's it for me. I'm going to turn it over to Lee.
Can I interrupt 1 second? Just for clarification too, because there's been a little bit of confusion about this. Our transition committee, their role is to figure out how we get from our current system to a UHP. That's the transition that we're talking about with transition committee, is like, how would you do it? How would you take what we have now and then move everybody over to a universal health plan? And so they're going to spend some time thinking through that process and report back. And so we really appreciate folks from this committee and members of all 3 of our other committees who are joining in that effort. And then just to also clarify, this committee, along with Finance and Revenue and Operations, the plan is that that all 3 of these committees will wrap up their work in March. So today is our February meeting. We've got one more meeting after today to sort of wrap up our work and our recommendations. And then Mimi and our staff and the board are going to need to focus on sort of reconciling all our recommendations April, May, June, and coming up with sort of a unified plan working with the transition committee. So I want to say that in spite of the fact that we're thinking this committee is going to wrap up its work in March, having delivered all its deliverables, thank you very much. There still will be opportunities for all of you to engage with the board, to participate in our decision making. We have learned so much about your expertise and your valuable opinions, and we're going to bring as much as we can forward, but it's just won't necessarily be in this committee format. So right now our plan is that our last meeting will be March.
Thank
and if
you,
anyone has
Helen.
questions about that, that's
Okay, I'm not seeing any hands, so we will turn it over to Lee and to discuss the behavioral health plan proposal and update.
All right, thank you so much. Yeah, let's dive right in. This is, as mentioned, our second time looking at these issues. What we're really looking for from this committee is whether we get the yay or nay to approve a preliminary policy direction for behavioral health funding alignment, integrated behavioral health payments, and integration model for behavioral health and primary care. As mentioned before, last time there was, I think, really strong substantive agreement on the bottom 2 of those. So mostly what we're discussing are some changes to the behavioral health funding alignment piece. Next slide. All right, so let's just dive right into it. Regarding the revised funding alignment, what we have changed in this, before it was really split out between what the various, and this is public funding only, I should say, where the various public streams were going to head with respect to being in a UHP versus not in a UHP. We've stepped back with the understanding of just how complicated and intermingled a lot of these funds are, and instead come to some categorical decisions or principles, as I put here, about how that funding should work. So essentially, we now have two buckets. We have behavioral health funding that overlaps with public safety, with the principle being that should remain independent of a UHP. So that would include a lot of what we see in the county financial assistance agreements, dollars specifically related to crisis services, those county dollars also related to forensic behavioral health, and those related to the Oregon State Hospital, as the Oregon State Hospital does tend to take a lot of patients that have those various legal issues, and it does fall a little bit more on the public safety side of things, as opposed to those broad-based behavioral health services. So the idea being those services, very important, need to be integrated absolutely. However, they should remain financially separately managed because of the strong ties to the legal system and to public safety, which is a really broader issue than healthcare. Now, the second category we have is behavioral health funding for services that have no public safety component. These should be aligned. However, as we are talking about public sources, do want to just add the caveat that this is all pending relevant federal approvals. But the goal is for these funding sources, the ones that do not have a public safety or a legal aspect associated with the behavioral health services, to be aligned. So this would include, of course, Medicaid, OHA Behavioral Health Division, Medicaid dollars that receive federal matching, and then federal SAMHSA block grants as well. And I'll just pause. This is, again, the one area that is different. I don't know if anybody has any comments, or Eve was very, very helpful in discussion, so I don't know if you have anything to add, Eve. James?
I'm wondering if you could help me delineate sort of the public safety component of this. It's a little unclear.
Certainly. So public safety is things like the crisis line, like the 988 kind of line. It's also related to, again, those forensic behavioral health services. So that is when there is an individual involved in the legal system that also has mental health issues, and it becomes not only providing treatment, but also a bit of a question of capacity and accountability from a legal sense, and wanting to differentiate those. So we're really talking crisis line, mobile crisis, and then those that have the associated kind of legal outcome with them.
So if somebody is temporarily committed to the hospital, what bucket does that fall into? Voluntarily or involuntarily?
I can answer that.
Yeah, thank you.
So there's a couple different scenarios where that might happen. So if somebody is accused of a crime and they plead guilty except for insanity, that is a legal criminal issue. They might be sentenced to the state hospital, if that's the case, or placed in the state hospital. That's sort of the legal aspect of it. If somebody comes into the emergency room and they say they're going to kill themselves, or they say they're going to kill somebody else, the physical medical hospital can hold them there pending evaluation, and that's separate. So commitment it depends on what they're being sort of committed for. But there's a whole stream of funding, I believe, correct me if I'm wrong on this, Lee, but there's a whole stream of funding in the legal system that is like a public safety. It's part of the city, county, state, federal funding stream, right? That accounts for the fact that as a community, there might be situations where somebody need mental health support as part of a legal or criminal proceeding. Is that right?
Yes.
Right. So it's a separate piece of funding. And I think this is only referring to funding here. This is where about the money. And so it's like just keeping that pot of money that's dedicated for that purpose separate from the pot of money that's dedicated for, I mean, for lack of a better word, the pure health considerations of behavioral health, as opposed to sort of the legal considerations. The legal considerations need to just be kept separate. Yes.
That's
Well,
what we're proposing.
as I think I've indicated, I have a grandson who was, I think his mother recently calculated in the last 15 years, he's had close to, I think it's like 100 different psychiatric admissions. From most of the time being picked up by the police and taken to the hospital. And I'm wondering to what extent that is a public safety issue or a mental health issue.
I think it depends on the systems he's tapping into, right?
Okay.
You know what I mean? Like, and so, Lee, I was hoping you would clarify the second bullet of these principles. When you say that, so there's two pieces here, and right now it's easy, I think, to kind of confuse them. One is how behavioral health is paid for, and then the other one is how behavioral health services are delivered, right? So it's the system of like who's available for treatment and how that treatment works, as opposed to where the money comes from to pay for that treatment. And I think, correct me if I'm wrong here, but when you say that behavioral health funding should be aligned when there's no public safety component, we want as much as possible for behavioral health to be fully integrated, to have parity with physical health issues, right? We have actually a law about that, and that behavioral health should be considered the same way as physical health is considered, and delivered in a system that meets people's holistic needs. And so to the extent possible, we want behavioral health and physical health sort of as part of one system, to deliver care in an effective and efficient way to meet people's needs. And so we're going to try to align the funding there wherever we can, when it's sort of part of the medical system and can be part of the medical system. However, there are certain cases where the funding should remain separate, as I said, because of the public health or legal. That doesn't necessarily mean that the treatment would be separate, right? So in terms of where your relative would be, how your relative would get care, that hopefully will be changed under this system, because the care system, the delivery system, is still part of what we're trying to reform. It's just sort of where the money for that care or that service comes from that we're trying to sort of separate out.
I didn't want to spend too much time on it. I just was.
No, it's important.
That's helpful.
It's really important. But Lee, did I miss something?
Yes, no, I think you stated it really well, which is the delivery of care. We want, however you enter the system, you're going to get the care you need. But there does need to be some differentiation when there are these other kind of public safety and legal aspects to it. But where we can, we want to streamline that funding, have it all flowing through a UHP in order to simplify things much more for providers. So right now that funding is highly fragmented. We're looking to get that down to 2 streams, UHP, or does this come out of the public safety bucket? And Chunwei, you've had your hand up for a little bit, so go ahead.
Thank you. My comment is very closely related to what Helen just mentioned. And my comment is broader than behavioral health, but behavioral health is just one example. Countries that has been implementing universal healthcare have been dealing with this for decades. But for the US, this is a new experience. That is, as an organization or agency administering universal healthcare, we are overseeing all kinds of providers while simultaneously dealing with different sources of funding. And so behavioral health is one example that once we implement that, and I think the transition committee may dive deeper into this, that is, we need to make sure we consolidate all the providers, no matter where the funding comes from. Roughly speaking, we will have funding directly from the UHP, but then we have second source of funding from multiple agencies. And that's something the system need to deal with it, to consolidate all provider services while separating funding source. And this is also something related to subrogations, and together with if we get waiver, Medicaid, Medicare, etc.
Yeah, thank you, Chandra. Yeah, that's a great point. That no matter where the funding comes from, the goal is to have a delivery system that has all the providers that we need, that has a stronger workforce, has a more stable workforce, that the care is more effective and efficient, no matter what the need for care is. But yeah, that the delivery, we're trying to get everybody on the same page. But yeah, that's a really good way of thinking about it.
Let me just give a quick example. In December, I had a relative who had to do some screening on hepatitis B and C. And so it's the same delivery system, went to the National Taiwan University's hospitals. But interestingly, when we register, when I have this friend registers, there's a separate item because control and prevention of hepatitis B and C has been Ministry of Health's top priority. So all the screening and treatment of hepatitis B and C, that funding came from Ministry of Health directly, not part of National Health Insurance. So that's just one example. The delivery system are unified, but then the payment system, so that's something we have to think about in the payment system. How do we differentiate the same services in the same institution, but the specific type of service funding come from different source?
Yeah, that's excellent. Thank you, Chandra. Yeah, so another way of saying that would be we're trying to not pay for things out of the UHP's pot of money that currently and in the future could be paid for by public funds, by the state general fund or by a city or whoever, federal funds, I don't know, whoever's paying for that now could continue to pay for them, and we could save money by not having the UHP pay for them. They should continue to be paid for by those other funding sources and not be a healthcare expenditure, right? Yeah. And in your case, in Taiwan's case, because they made it a public health priority for control of hepatitis, that's why it's like a city priority, right? It's a municipal or a regional priority. And so then it comes out of an agency budget rather than the health budget.
And if I may, I just have a quick question about that. So
Yeah.
what I thought I heard Dr. Chi talking about was the system will need to braid together funding from multiple sources, so it is a single system of delivery. And so is that right, Dr. Chi? And that so the person receiving the care, it's invisible who's paying for it. They're just getting the care. But the system built on is intended to weave together, say, public health prevention funding and so on.
Yes, once the system is implemented, the agency in charge of administering the universal health plan need to coordinate the funding sources. And so, like Helen said, separate what sources came from UHP, what sources came from other agency, other program. But from the patient's point of view, they are blinded about those sources.
Yeah.
And if I can add, I flew over the topic of subrogation, which is essentially what we were talking about, which was occurred at the operations committee. And that very topic has to do exactly with this. So if, for example, we think about auto insurance and the auto insurance paying for if someone was in an auto accident, that insurance money would pay for the health care of the person who was in the accident. Well, if you're a provider, then it can be challenging to get money back, say, from an auto insurance place or from other things. So what the operations committee has discussed is that, yes, those funds, as Helen talked, we still want those funds coming in because they do come from a separate source. They come from a separate bucket. However, what the Universal Health Plan would really like to do is not just for the patient, but for the provider, that it will look the same. So in other words, a Universal Health Plan administrative system, the provider will be paid in the same way as they normally were. It will be the work of the Universal Health Plan to then go and get money from that third party. So again, reducing the burden on providers while still sort of making sure that those funds that come from other places are available for use. So I'm sorry, I don't want to go into it too much, but I'll leave it there.
Yes, that's exactly what Taiwan has been doing for the last 30 years.
Mm-hmm. Right. It's the auto insurance. It's things like workers' compensation insurance. To some extent, malpractice payments are related to lifelong medical expenses. So there's a bunch of different areas where we have patched together because for so long, so many people have been uninsured in this country that we have all these safety nets of like, if you're in a car accident, how would you pay for your medical care if you're injured because of, right? So like, if you're injured at work, then your employer has to pay for your healthcare. So there's all these other systems of payment that we want to make sure that we capture, but still build an integrated delivery system, which is pretty challenging. But yes, I think we're all on the same page that we're hoping that it's seamless for the patient and provider, and just we're braiding the funds together at an administrative level.
But then the UHP would be responsible for collecting, finding, collecting all of those sources of revenue, the grant reporting, the grant applications, right? I mean, there's a lot of sort of administrative burden there that presumably the UHP would be taking ownership of that as well.
Well, yes, I imagine that's true. You're talking about like SAMHSA block grants and that kind of thing.
Sure. And,
Yeah.
the other insurance, the workers' comp, like auto insurance, I mean, all these other sources of funding that come here, right? Like the
Right.
UHP is taking on management of all that revenue.
Well, to some extent, this is going to get way beyond what we're capable of doing at the board, but like how I imagine it is if we have enough support for UHP and if it's going forward, there will be a whole slew of legislation about how it would happen. And I imagine that one piece of legislation would then cover this subrogation part. Like how do those insurance companies, right? That's like a state legal thing about all these other insurance companies that have existed. What will be their role under a UHP and how will those payments flow? I think a lot of it will be simplified and we'll need a lot of legislation to make that happen. So I don't think those companies are going to still exist in their current form and we still have to go chasing that money. I think it will be dealt with somebody way smarter than me. Like, I don't know how that would work, but it seems like there's a legal piece there about what is the role of those companies in terms of grants from federal government. Yes, because we're one state in a country, right, trying to do universal health plan as one state, we're still going to have a lot of relationships with the federal government around waivers for Medicaid and Medicare, around grants for things like SAMHSA. And I know the Bureau of Primary Health Care traditionally gives grant money to federally qualified health centers. Like there's still a lot of federal money that, that is applied for and brought into the state. And as one state trying to do single payer, those kind of relationships will still need to exist and that'll still have to be administered. Yeah, it's not ideal, but.
And Jim has his hand back up.
Yeah, I was a little bit concerned when I first saw the reference to subrogation. From my perspective, this plan ought to be primary in all situations and kind of obviate the need for a medical portion to auto insurance and such. But to the extent that it is all transparent or not transparent, maybe hidden from the member, I gave a number, dozens of presentations to members of the Amalgamated Transit Union on single-payer healthcare. And the ATU has a large Canadian membership. And people in the audience would ask the question, what happens in automobile accidents? And the Canadians didn't understand the question. Why does it matter?
Right.
So as long as that is the situation, I think that's where we want to be. We want it to be transparent to the individual participant, and not have the participant caught in the middle. And one of the things, especially when you're dealing with workers' comp, that is an issue, is most insurance companies negotiate prices with providers. Workers' comp generally doesn't, and that can become an issue.
Right. But I think, Jim, you're exactly on target there. Like the idea would be, that's what I was alluding to, is like I'm making this up, you guys, this is not, but like there would be some sort of legislation where like auto insurance companies no longer cover medical expenses. They just don't. They cover damage to your car or damage to the other cars or damage to property or whatever. And that's the purpose of auto insurance, is that it covers those things, but there isn't a component of medical coverage. And instead there's some way of bringing those funds in. I don't know. Again, like this is a very complicated legal topic, but it gives you a taste of like how tricky it is to do single payer as a single state, because there's all of these sources of money that's paying for healthcare, and we're trying as best we can to unify them, but there are just so many pieces coming from so many different directions that it's going to be a complicated legal mess to sort out.
And Chunwei.
Yes, this is related to both Jim's and Helen's comment. Even if eventually the state legislate that the auto insurance will no longer be covering medical expenses, but we will still have to deal with subrogation, because there will be out-of-state residents that who have out-of-state auto insurance.
Right.
The auto insurance pays for their medical care, and that's just one example.
Right. Yeah, you pull on any one of these threads and it becomes very long very quickly, you know.
All right. I think I'm gonna jump back in only because I know that our operations committee is dealing with the subrogation issue, and I don't want us to get too sidetracked. We have a lot of topics today. So let's move ahead. Next slide, please. All right, so the next aspect that we discuss in the behavioral health proposal that we're asking this committee to take a vote on today is the payment architecture. And we had more detailed discussion of this last time, but I was trying to keep this short since it seemed pretty non-controversial for folks. Essentially, what we're discussing is having a bifurcated behavioral health payment, part of which applies to what clinical services were provided at the time, and a second part that is, I don't even want to say an add-on, but just included with those, that is intended as kind of a capacity infrastructure payment. So really acknowledging that what we're asking from behavioral health providers in a very unique sense, similar to emergency care, is not just for them to provide care, but for them to have the capacity and the space to accept patients and to be able to expand services, to be able to offer things like phone lines if possible, et cetera. So making that kind of a formalized part of how we would reimburse behavioral health care. Next slide, please. And then finally, we discussed the integration of behavioral health with primary care, using those regions that the board has determined. These regions are not service areas, they're not networks. I do just want to emphasize that. These regions are essentially ways to coordinate care in a slightly more local manner, however. Regions have greater insight into exactly what providers are in their area, and therefore are best positioned to be able to decide what level of support they would like from the public corporation versus managing how they're going to do that themselves. So they could choose model 1, 2, or 3, or they could even choose hybrids of these, depending on if their region had maybe more urban areas or more rural areas where they wanted to take advantage of support from the public corporation. So really trying to provide that flexibility for meeting the behavioral health need, however it is best determined, but allowing that kind of autonomy at the local level, depending on what resources there are. And I want to be clear, we're talking about really base primary care and behavioral health services here. We're not talking about high-level crisis services. That is, of course, a shared resource across the entire state. All right, next slide, please. And so this is in sum what we have contained within that proposal. And I know Isabel has that written proposal to skim through if needed. But we're looking for this committee to give us the go-ahead or the no-go on these 3 aspects. And with that, I will turn it back to you, Chair Blanca.
Great. Does anyone have any questions, first of all, on that little bit that Lee just went over there at the end? Jamie made a comment in the chat that's really important, that we should choose a different word other than capacity when we're we're talking about it because that's a great example of sort of a legal definition, capacity to make decisions. But enhanced access or expansions of care or something like that, like something that implies they're more available without using that word capacity. So we can make that. So there are three pieces of it. As Lee said, the second two we went over quite a bit more in our last meeting. And the first one is what we were just talking about today. So we just want to make sure that we have some agreement on these three buckets. I think we could either do a roll call or do thumbs up in the chat or thumbs up on the screen. Do people have a preference? I don't think. Let's do a thumbs up on the screen if everyone's able to do that. So to just get a sense of, let's look at the first bucket to approve the three funding alignment buckets. Lee, is this wording from the last time?
Yes, it is. I would maybe suggest that we're looking to prove the sort of categorical distinction between the public safety legal versus kind of purely behavioral health services.
So this is a PDF. You can't edit it in real time.
Yes.
Okay, so I want to.
Yes, you're correct. The proposal is 2 buckets.
I want people to feel confident about what they're voting on. So you can ignore this first line here because that's from last month. What we're voting on is that the funding for behavioral health will be separated into funding related to safety, public safety and legal concerns, and then to the extent possible, align it with the medical. So can you go back to your slide about that? Lee, just I want people to be able to see. I'm not going to be able to recall from memory what it says exactly. This one. So that the funding alignment looks like this, that behavioral health funding that overlaps with public safety should remain independent of the UHP, and behavioral health funding for services with no public safety component should be aligned with the UHP pending relevant federal approvals. So that's what we're voting on, is that principle. So just based on this slide, let's do a hand raise if you are in favor of including this in our straw proposal to the board. And if you can't raise your hand for some reason, use your voice, come off mute. We got Isabel. I'm going to leave that to you because I can't see. Looks like
I'll go down the list and make it a little bit easier. So Tony German was a yes, Gabe yes, Peter Merritt yes, Jim McGee yes, Chun Wei Chi yes, and it looks like they always move around. Betsy Boyd Flynn is a yes. Jamie Osborne is a yes. Peter Addy is a yes. Helen Belanca is a yes. Angela Michalik is a yes. Did I miss anybody? Or did we get y'all? I think we got everyone.
Okay. We should do a roll call next time. That'd be easier.
Yeah, I think roll calls are easier.
Okay, sorry. Trying to make it easy for everyone. I'm not sure what that is. Okay. So then the second piece of our proposal, the second and third piece are what we discussed last time. Lee, if you can just pull them up on the slide. So let's look at your slide about the architecture. So this is what we're referring to by architecture, that the behavioral health would be paid with two separate buckets of money, one for direct clinical services and one for expansion and access. And so let's do a quick roll call in favor of including this in our proposal.
Helen Belanca,
Yes.
Chun Wei Chi,
Yes.
Yes.
Peter Addy,
Yes.
Gabe Bandine,
Yes.
Betsy Boyd Flynn,
Yes.
Mike Durbin is absent, Rob Fissette is absent, Tony German,
Yes.
Eve Gray is absent. Rosemary Hemmings is absent. Julianne Horner is absent. Max Kaiser is absent. Jim McGee,
Yes.
Peter Merritt,
Yes.
Angela Michalik,
Yes.
Jamie Osborne.
Yes.
Thank you. That passes.
Great. And then the last piece is the regional model. So it's the model where we take into consideration, we allow regions to determine how they would build their access. And this is the model we reviewed in depth last meeting. There are 3 different models, and really they are aimed at the density of the population and how easy it is to access services. So what component is in person, what component is virtual. So, you know, if you have like a lot of access versus you need more virtual support. So there are 3 different models there to meet the needs of rural communities. Again, this was the model developed by Judy Richardson with a lot of input from communities. So last meeting when we talked about this, I think we were all pretty pleased with it. So just as a formality, if you are in favor of doing this regional access model, allowing regions to decide how to integrate care, let's do a roll call vote for if you're in favor of including this in our proposal.
Helen Blanca,
Yes.
Chenwei Chi,
Yes.
Peter Addy, Gabe Bandine,
Yes.
Betsy Boyd Flynn,
Yes.
Mike Durbin is absent. Rob Fazette is absent. Tony German,
Yes.
Eve, Rosemary, Julianne, and Max are absent. Jim McGee,
Yes.
and thank you, Jim. Peter Merritt,
Yes.
Angela Michalik,
Yes.
and Jamie Osborne.
Yes.
Thank you. That's everybody.
Okay, thanks, Jim. We appreciate you participating as long as you can. Thank you, everyone. That's excellent work. So special shout out to Eve Gray, who worked with Cheryl Ramirez, one of our board members, on the funding model, and especially to Lee Hastings, our policy analyst, who got all of this together. Thank you so much for your work. And thank you long distance to Judy Richardson too for her help with this. I think the opportunity to reform the way we provide behavioral health is one of the great opportunities in a universal health plan, and I'm really excited about this proposal. So thank you all for your work and support on it. And turns out we're on time. So I'm gonna pass it back to Lee to go to prescription drugs.
All right. Thank you so much. Really appreciate the thoughtful conversation,
Oh,
everyone.
I apologize, Lee. Can I just say one more thing?
Mhm.
There will be a formal write-up of the full proposal that will go to the board, right?
Yes.
Okay, and so could we send that out to everyone on the committee then to see the full proposal before it goes to the board? And then I invite any committee members, if you look at that and read it and want to give feedback, to let us know. I think it's important to see the actual official full proposal before it goes to the board. But it won't include anything new. It'll include everything we talked about today. It'll just be written out in more detail.
Isabel, I don't seem to be able to share.
You should be good now. Should be able to.
Here we go. All right. And there we go. All right, so we are going to chat a little bit about prescription drugs. This is really meant to be an overview. At the end of this, we'll discuss some of the ideas out there about cost containment related to prescription drugs, but then we're gonna, I think, take a break and then roll into a more official conversation on cost containment. So for now, consider this just sort of a primer on prescription drugs. I'll be candid, I am no expert on prescription drugs, so absolutely ask your questions, but I may have to defer to further research. But there's some pretty interesting stuff here. So just to get us started, want to always make sure that we're on the same page here regarding what we're talking about. So a prescription drug, I think we all know this is a substance that's intended for use in the diagnosis or treatment or prevention of disease. Now, we access prescription drugs really in two ways, through retail pharmacy and through medical pharmacy. Retail pharmacy is what we're typically talking about when we talk about prescription drugs. And that's when you go to your local pharmacy and you pick up your prescription, or perhaps you get a mail-in prescription. And that is how people access their prescriptions kind of on a day-to-day basis. It's also important to remember, though, we do have another side to pharmacy, which is medical pharmacy, and these are prescription drugs that are administered directly by a healthcare practitioner. So this could be when you're in the hospital, when you go in for an office visit, something that is administered on site. Additionally, when we're talking about prescription drugs, we have two main categories. There's sort of a third that we'll talk about. But typically we're talking about whether it is brand name or generic. And these are essentially drugs that are functionally identical with respect to the formula. However, the brand name is sort of the original formation of the drug, tends to be more expensive, and in some cases, for certain individuals, they respond better to a brand name versus a generic drug as well. So that can account for some of the differences we see in prescribing. Now, this will be news to no one, but I would be remiss if I didn't mention it, that of course, when it comes to prescription drugs, we have very high costs and very high utilization here in the United States. The US spends more per person on prescription drugs than any other country. In fact, we make up 4% of the world's population and we consume 8% of the world's prescription drugs. So assuming we were going to do this equally, we're on average consuming about twice as many prescription drugs as you would think we should. A little over 60% of Americans are currently taking at least one prescription, and more than a quarter are taking 4 or more. So that's a pretty substantial amount. Average out-of-pocket drug spending is about $1,400, and this is just what patients are paying out of pocket. So of course, this does not even begin to touch how much this is impacting the overall healthcare system. And of this, slightly less than a third, about 30% of Americans in this survey noted that they have reduced their prescription drug costs by doing things that are, not necessarily what we would want, such as skipping doses, cutting pills in half, or using less effective alternatives that they can purchase maybe over the counter. Now, as we dive down into Oregon, we can see prescription drugs make up a pretty large chunk of our overall healthcare spending pie. In fact, that light blue that you see popped out, that 16%, this is retail pharmacy only. So remember how I talked about there's also medical pharmacy? This is not even the whole slice. Somewhere floating around in that hospital inpatient, hospital outpatient, and professional, there is also additional pharmacy costs. So we're really talking about quite a lot of money here. Now, across our various sectors, the blue shows how much is spent overall for each section of our healthcare population when you look at Medicaid, commercial, and Medicare fee-for-service, Medicare Advantage. Commercial occupies the largest portion, but that's also because there are the most people there. When we're looking at the per member per month, which is the little orange dots, we see that, in fact, as we would probably expect, the highest spending is found amongst our Medicare populations. And in fact, the lowest spending is spent on Medicaid, although certainly some of that is due to Medicaid's lower reimbursement rates. But in general, they are still less than half the cost of what we see on the commercial side when it comes to their prescription spending. Now, again, we talked about that brand name versus generics. The spending difference here is pretty striking. When we look at just the US, it's really fairly astonishing. Brand name prescriptions account for about 10% of all prescriptions, but are estimated to be about 80% of all spending. So I mentioned that they're more expensive. They are quite a bit more expensive. Don't have necessarily apples to apples figures for Oregon, but Oregon does release this information by certain payers showing their spending on prescription drugs by category. This is where we'll see kind of that third category that's sometimes broken out, which is specialty drugs. These are drugs that are really, really specialized, extremely costly. But if we're looking at this figure just for kind of the difference between generic and brand name, we see that indeed there does tend to be more spending of those brand name drugs, probably not as high as the 80% on the national scale, but I would say around, maybe 65% of all of our prescription drug spending, just based on this particular graphic. And it is highly variable, I will note as well, by plan. But we still do see that those brand name drugs, the use of them really does add up. Chair Belanca.
Sorry, Lee, I don't know if it's just me, but the legend at the bottom is cut off on this slide, so I can't tell. What does the gray, orange, and blue represent?
Oh, I'm so sorry. The gray is the specialty drugs. The orange represents the percentage of spending on
Brand name. And blue is generic.
And blue is generic.
Yes. Orange is brand name and blue is generic. So again, highly variable, but we do see that similar pattern where spending does tend to be higher for the brand name drugs as compared to the generic for most of these plans. All right. Now, when it comes to Oregon, we of course are a state that really regulates our healthcare environment pretty closely. We have a lot of oversight, and you can see there's really been an evolution and taking a closer and closer look at how prescription drugs are impacting the overall affordability of healthcare. So in 2011, Oregon stood up its prescription drug monitoring program. This is run through OHA. And this is really more for the prescribing of certain controlled substances. So those pharmaceuticals that appear on schedules 2, 3, and 4 really go into this system. So starting to take control over some of those prescription drugs that can lead to more negative outcomes. In 2018, the Oregon Drug Transparency Program began producing its annual reports related to rising prices of prescription drugs. Now, the Drug Transparency Program required drug manufacturers, pharmacy benefit managers, and others to submit information related to their price changes. Excuse me, let me just finish this slide and then I'll turn it over to you, Chair Belanca. And then finally, we have our Prescription Drug Affordability Board, affectionately known as a PDAB. This was enacted in 2021. This board undertakes comprehensive affordability reviews of insulin products, as well as certain select other prescription drugs that are submitted for review. So it's a bit of a changing list. It's not all drugs, but it does aim to look for those that are experiencing some of the sharpest increases or having the greatest impact on, public health and access, et cetera. Chair Belanca.
Apologies, that was left over, sorry.
That's okay. You gave me a chance to have a sip of water, so I appreciate it. Oops. All right. Okay, now we are getting into kind of the complicated stuff. So prescription drugs, I think part of why we can conclude that they are so expensive, it's a very multifaceted question, of course, but they essentially have their own system that sits right alongside what is already a very complicated healthcare system. So I found this pretty fascinating, which is why I included it and why I'm going to walk through it a little bit, simply because having worked in healthcare policy for 16, almost 17 years, I feel like I didn't really even have a very good understanding of it. It is just it's pretty dense, pretty difficult to understand. So there is this fantastic figure, just really demonstrating kind of the flow, and you don't need to memorize this or understand it. We're going to go through some of the key players here on the next slide a little more slowly, but I really wanted to include this just to kind of take it in and get a sense of, wow, like this is just really complicated stuff. There are a lot of folks involved. There's a lot of different negotiations and payments changing hands. All right, so let's look at some of our major players here. First and foremost, we have drug manufacturers. This is really the source. These are the folks that are developing and marketing the prescription drugs. This is where it all begins. Next down from them, we have the distributors or wholesalers. Important to note that there are 3 distributors that account for almost the entirety of the US market. So this is a really highly concentrated area of those folks that are actually pushing the various prescription drugs out to the pharmacies. It's really just a very small number of companies. Sure to invite the most controversy. They're on the side, so not part of kind of that direct chain of where the pharmaceuticals actually go, but very, very involved in the financial side of it. We have our pharmacy benefits managers. Similar to the distributors, we see really, really high concentration. The top 3 cover 80% of US prescription claims. We'll talk a little bit more about PBMs, but they're also the ones that are working with pharmacies to assemble networks and to set a lot of prices for the pharmaceuticals. And then finally, we have those retail pharmacies. These receive payments from the pharmacy benefit managers and from patients to reimburse them for the cost of dispensing those pharmaceuticals. All right, so what all goes into a prescription drug price? Well, it's pretty complicated. It involves all of these different folks. Essentially, the pharmacy purchases that prescription drug from the manufacturer and from the distributor. Patients pay some. The PBM then pays the pharmacy. The payer then reimburses the PBM. And then we have this complicated element called rebates, which are discounts that are negotiated, are paid from the manufacturer to the PBM, and then the PBM returns most of that to the payer. So if we want to take a look at what that looks like in terms of the money, it's something like this. The arrows indicate where the money is going. So it's really kind of all over the place. Again, part of what makes this both fascinating and really complicated. So a little bit more about pharmacy benefit managers. Essentially, what do they do? Why are they there? Why do we have this third party? Well, they are there essentially because prescription drugs are so complicated that they almost require their own kind of insurer, and that's what a PBM really is. PBMs do all of these various functions that, someone like me definitely thought that insurance companies did, but it turns out insurance companies really kind of use this third party instead. So they do formulary management. They create and manage the formularies, and those are the lists of the medications that are going to be covered by health insurance. On that formulary, they also determine which drugs are considered preferred, which often means that they are subject to lower cost sharing amounts as opposed to those that are non-preferred. They manage those pharmacy networks. So I mentioned this before, but they're really working with pharmacies to assemble networks of where patients that are members of a particular health plan can go in order to fulfill their prescriptions. And they're setting that reimbursement rate, much like an insurer, but again, within the limited scope of prescription drugs. PBMs also handle all of the administration associated with processing those claims, doing out the reimbursement, and having any kind of clinical drug programs to manage drug utilization overall. So the really important takeaway for me here was that PBMs, since they are fully managing this drug benefit, they're actually the ones that are determining what that pharmacy reimbursement is. It is not actually that payer. Now, the other piece I wanted to touch on related to PBMs is this rebates and discounts. So what a lot of folks see as the value of PBMs, and I'm not going to make any personal judgment about that, but is that they are able to negotiate some of these discounts on drugs that can ultimately save the insurance company a bit of money. As you may remember, or you may not, because that animation was tricky to follow. PBMs receive these rebates from the manufacturer, and then they actually pass them on to the payer. And in fact, as you can see in this pie chart here, they pass on pretty much all of it. Close to 99% of that amount does in fact go back to the insurer. So the insurer does save money based on the PBM have negotiating these rebates and discounts. However, there is not a lot of transparency around this particular process. Rebate amounts are kept a secret from PBMs. In fact, even the insurance company often doesn't know the terms of that arrangement. We do have some data from PBMs that was reported to the Prescription Drug Price Transparency Program. And you can see that it's pretty variable. If we don't look at Kaiser, which sort of has its own its own way of doing things, we see that those rebate amounts range generally from 10% up to 27%. So that's the amount of prescription drug costs that the insurer is actually able to save by doing business with the PBM. No surprise here, but PBMs have come under a lot of criticism. The Federal Trade Commission in particular is really not a fan of them. And a big part of that is the lack of transparency. So in talking about those rebates, for example, nobody really understands how those rebates are working. There isn't good insight into how PBMs operate or into how they're setting prices, designing, contracts with the various pharmacies that are part of their network. There is some concern about preferencing of certain pharmacies. This is especially true when you look at the consolidated market power in those top three, noting, for instance, CVS has a lot of its own pharmacies, and it's not clear to what extent they are preferencing their own pharmacies for distributing those particular drugs. So there is a lot of criticism because they're just not really understand very well, and they are not particularly forthcoming about their processes. Next slide. Now, Oregon does have some regulation of PBMs. They are required annually to register with DCBS to do business. And they are subject to a couple of these various stipulations meant to kind of keep them in line with doing business the way we would hope that they would. For instance, when it comes to a 340B pharmacy, not providing any different reimbursement, not retroactively denying or reducing payment on claims, not imposing fees on a pharmacy at the point of sale, providing certain notices to pharmacies, not prioritizing mail order pharmacy over in person, things such as that. Now, we don't have a lot of information regarding medical pharmacy, but I did just briefly want to touch on it because it is sort of a hidden element of our pharmaceutical system, I think. And I think the big player to be aware of here is really these group purchasing organizations, or GPOs. These are entities that allow hospitals to essentially band together to secure more favorable pricing and terms from drug manufacturers. Now, notably, hospitals don't necessarily need something like a pharmacy benefits managers. Hospitals tend to have their own formularies and their own policies related to prescription drugs, and they're often fairly strict, as you might imagine. And 340B, this is a key part of the medical pharmacy system. We have these 340B hospitals, which are eligible for certain reductions on prescription drugs, as well as having ceiling prices. This applies to certain eligible hospitals and clinics that can qualify by having a particular status, such as serving a lot of lower income or federally insured individuals, etc. So they are able to purchase these drugs through the 340B program at some savings. However, 340B participants are prohibited from purchasing drugs through the group purchasing organization. So there is a little bit of a trade-off there. Some providers might find that they can get a better deal with a group purchasing organization and therefore decline their 340B status. Just kind of an interesting thing that I thought I would note. Now, finally, as I'm wrapping up just this general overview, of course, wanted to touch on what the Oregon Health Plan does in terms of drug management. Importantly, however, this applies to a pretty small population because the Oregon Health Plan does operate predominantly through the CCOs. So what we're talking about here, this is really just the fee-for-service population. Each of the CCOs, of course, is going to have its own process. But to the extent that we were looking to what they have done, Oregon is part of a multi-state drug consortium, a group of 15 different states that collaboratively negotiate drug rebates for their various programs. And through this, OHP has a list of the most cost-effective drugs that is part of their preferred drug list. And also, just kind of for reference, just to know, drugs that do not appear on the preferred drug list, those are the non-preferred drugs. Non-preferred drugs do require prior authorization from OHP. The exception is that non-preferred mental health drugs do not require prior authorization. So those can go through pending the order. All right. And we will return to this. So right now, we're just going to talk about some cost containment strategies related to prescription drugs, but this will all get wrapped back up after our cost containment section here. So all of these are recommendations that were raised by the Prescription Drug Price Transparency Board. I do see this green line at the bottom, which is unfortunate. It's cutting off the citation, but excuse me. But if you are interested in this, I do strongly encourage you to look up Oregon's Prescription Drug Price Transparency Program 2024 report, because that's where these are from. It's a very interesting read. So these first set are really around making what PBMs are doing, what manufacturers are doing, more transparent, trying to understand what is the impact of these things. So manufacturers offer these patient assistance programs. These have been found to increase the uptake of brand name drugs over generic drugs. There are also these programs that insurers and PBMs have called copay accumulator programs, where there's essentially different ways of acknowledging outside financial assistance for drugs that may be creating some financial incentives or at least mitigating financial disincentives for patients, making it more appealing for them to also select brand name drugs. Now, these are really just transparency strategies because at this point in time, it's not really known how these impact behavior, but there is the sense that these practices encourage more patients than maybe need to in getting brand name drugs, which are the more costly ones, and therefore adding cost to the entire system. The second set of strategies recommended by the Prescription Drug Price Transparency Board are related to bulk purchasing. There are a lot of ways in which the state of Oregon is not utilizing the full purchasing power that it could have. So it could do more with respect to the multi-state purchasing authority. It could require more of its health entities, such as the CCOs at the Oregon State Hospital, to purchase drugs as a collective. None of that is currently in place right now. So the purchasing is pretty fragmented, leading to smaller dollars, leading to less leverage. Centralizing the state Medicaid drug purchasing, and centralizing pharmacy purchasing and analytics. So right now that is fragmented, again, across different systems, and really bringing that all together is something that they recommend. And I will take questions as soon as I end. There's just a couple slides here. Another issue that is, or another solution, I should say, that's been raised by some folks is what I call PDAB 2.0, upper payment limit. So in this graphic, all the states that are filled in have a prescription drug affordability board. Oregon, of course, is one of those. The states that appear in green have PDABs that have this upper payment limit authority, which essentially means that the board is able to set a maximum amount that can be paid or billed for a prescription drug. This is something meant to control costs and ideally improve affordability. Now, this has a lot of critics. Folks argue that if you set that upper payment limit, pharmacies might not want to carry the drug because they're only going to be able to sell it at a loss. There are not a lot of states that have these in place. We don't have a lot of data on it yet, but it is an idea that's out there that is something that is starting to gain some traction. In 2024, Oregon's PDAB did issue a report with recommendations for how we could implement something with an upper payment limit, but it's not clear, again, if that's something that, that will happen in the future. All right, and with that, I will happily take questions. Peter Addy, I believe your hand was up.
Yeah, thanks. Just for those last two slides, recommendations from the Transparency Board and whatever, those are recommendations for within the current terrible healthcare system that we have now. These are not recommendations for a proposed universal health plan. Is that correct?
That is correct. I think part of the reason for including them is the idea that, yes, while they envision our current highly fragmented system, they nevertheless could potentially provide some insight, some of that transition pathway. But of course, that's up to all of you to decide. Chun Wei.
Thank you for your summary, very detailed information. I have one question and one comment. The question I have is in your earlier slide, you mentioned about the US with the world's 4% population consume 8% prescription drugs. And I suspect that 8% was not the quantity of prescription drug consumed, but based on the price. And assuming it's the statistics based on price rather than quantity of prescription drugs, then it might be overrepresented in terms of the actual prescription drug the US consume, because compared with most other countries, we have the most expensive price on prescription drugs. For example, on average, most of the prescription drugs made in USA we are twice the price of Canada or UK. And I talk about this in my class, and I have a British physician. Immediately he went to check, and he found out a large list of prescription drugs in UK. They are selling half the price or even less. So that's just a question. I suspect the statistic was based on the price, not on the actual quantity. And then my comment is, yes, those cost control strategy are based on the fragmented, largely the private insurance systems. And I have done a little bit of a review on how other universal healthcare system, usually national level, deal with prescription drugs. They're largely on two patterns. One is the payer, usually the government, negotiate with the pharmaceutical companies. So they're negotiating the price because they have the huge leverage to include in their formulary. So they usually get a huge discount, even though they may not be do direct procurement. But those countries who do the negotiation, their prescription drugs are far lower than the US, even for those drugs made in USA. The other group, actually, there's a country, for example, Norway, Brazil, and in Canada, it's by province. Some provinces also do that on direct procurement. So those countries who did direct procurement, they not only negotiate the price of each category of prescription drug. The government actually did the direct procurement. They pay for that directly and then distribute to their pharmacies, to their clinic and hospitals. So these are the two possible models we can consider as a universal health plan rather than what the existing. And of course, we can definitely bypass the pharmaceutical benefit managers. By the way, one of the reasons U.S. ends up paying the highest prescription drug, even for those drugs made in the USA, was, remember, in the 2003 Medicare Modernization Act, but to include the prescription drugs, it was written into the legislation. It prohibits the federal government from negotiating prices.
It's an excellent point. Thank you so much. Peter.
Yeah, just more. It sounds like I'm looking at the complex chart where you for the prescription drug payment system, and it sounds like what we need to do then is, as a state, we need to manufacture our own generic drugs that would account for like 80% of the drugs, pharmacy retail drugs anyway. A universal plan, it sounds like, would be kind of acting as its own pharmacy benefit manager or cutting them out, or I think we should, like, it sounds like we don't want to deal with PBMs or replicate that in our own system. So we kind of act as our own PBM, I'm guessing. And then I don't think anyone has really talked about this, but I would love to see also state-owned retail stores like a CVS or a Rite Aid have a UHP pharmacy as a corner store or whatever we would call it, or maybe a Care Oregon if you want to go with the CCOs. But if we create our own drugs at the top, and then if we sell our own drugs retail at the bottom of the chart, that would vastly simplify things. That would cut out a lot of overhead. That would make things very transparent, get that nice vertical integration. So it sounds like we want to take over as many of these boxes as we can in our system. I guess that's more of a comment, but the question then, so specifically for the PBM, it sounds like we want to, in our proposed system, we would want to like cut them out or like make our own PBM. Is that right?
I think Tony was next.
Helen, I don't know if you put up your hand if you wanted to respond to the question.
Yeah, I was gonna respond really quick. I think so PBMs are like is where insurance companies are sort of outsourcing their pharmacy benefit to just a different group, right? Like you just handle the pharmacy because they're dealing with everything else. And as Lee alluded to, there's a lot of lack of transparency there. And I think, for simplicity's sake, what we say is, PBMs wouldn't exist under UHP. The UHP does, of course, have the responsibility to negotiate drug prices and to develop a formulary and all the things that PBMs do. But we would want to do it in a more transparent way. And obviously with consolidated markets get better pricing. So just for sake of simplicity, I would say that the goal here would be eliminating PBMs and then developing a more transparent strategy to negotiate drug prices for the UHP. But if anyone has any other thoughts on how that would work, I'd welcome that.
Yeah, I might jump in on that. I think the landscape to add to this conversation is that we have 16 CCOs that are negotiating their own drug pricing, usually instilled with their own PBMs. Then we have other payers that are doing that as well, and the multitude of those. And with market power, really what I think we're looking at, and when PDAB is done, is to find that to bring when Chair Blanca is stating is consolidation of that market power. We've seen that as evidenced when we've changed the game to have Medicare do drug price negotiation. John mentioned that was limited for a number of years and led to the dilemma where we find this. And so I think the drive for the governance board is, one of the big inroads in cost reduction is to remove the redundancies and the inefficiencies, and also remove the price that we spend for costs. And that's what the upper pay limit attempt is to say, well, you can sell the drug whatever you want, but we're only going to pay this because we think this is what is a fair market price based off of Medicare. And that's what Maryland is doing and what Colorado is doing. And now a couple other states are going to pick up steam. We looked at this. Actually, we're going to start looking at this on the Committee on Affordability and the Oregon Health Policy Board and some of these different policies with that. We do have some other things that add to this conversation, some constructs in the state, which is Array RX, which is a PBM that the state does negotiate with other states across the country. I think it would be very interesting to continue to look at that. But, essentially, we're going to probably need some entity that's going to need to do the price negotiation, whether that's a single PBM or whether that's on the governance board or the public corporation doing that. I would suspect that given, the ins and outs of that negotiation, it probably will take the shape of a PBM. But if it is a single entity, it could be regulated enough that it has transparency and that it could have accountability with that, which we don't in any of these PBMs. Nobody knows what anything is doing. And the state auditor for the Oregon actually looked at this question. You can see a number of people on this call as far as the frustration with PBMs.
All right, and Betsy?
Yeah, if I could just add, I think one of the advantages of, I think it's not impossible to imagine, as Tony was saying, that there is some value in the functions that a pharmacy benefit manager or a formulary manager of some sort, the function that they do. One of the challenges that, as I see it, of the current system is that the PBMs are not necessarily like legally obligated to act as a fiduciary, right? So, a discount on a price is great, but if the price is way higher than it has to be, the discount is still is meaningless. And so what we know from the way we've seen some of these negotiations work is we'll completely overprice this drug over here and give you a better price over here, and you agree to that because we're going to give you a really good rebate. And it's just all. So I think, again, that transparency and understanding that sometimes I think one of the pieces of the negotiation, or where frankly the rentiering is that balancing the cost of drugs across a whole formulary. Some things are very expensive, some things are very cheap, and that is where some of that manipulation comes.
One thing else I wanted to add to the conversation, I think, Peter, it's an interesting idea to think about our own manufacturing, but I think it's looking at what our skills are as a state and what our resources are. There are so many different medications out there. Perhaps maybe we might fund some space where we could promote manufacturers to come into our state in this process. There are some really, actually surprising enough, generic drugs are really hard to make in this country right now. There's a lot of drug policy that's changed over time, and there might just be one or two manufacturers across the country that are producing one particular medication. And that's actually caused quite a bit of some supply chain issues with that. So I think we wouldn't be able to manufacture the breadth of interventions and medications that we need, but perhaps we might be some. But I think we're still going to need to be able to do that contracting for the breadth of interventions that we want.
Chair Blanca?
I was just going to say, I really like Betsy's point about the thing that makes PBM so controversial. While they do have a function, I totally obviously agree. They're serving an important role, which is why they exist. And it's that fiduciary responsibility that you called out. Like they're serving, you know, nobody can tell, nobody knows what those deals are, even the companies that they work for, right? And so that role of having some sort of an entity that manages the drug benefit, but has a fiduciary responsibility back to the UHP and to the people of Oregon instead of to their own ends or to some insurance company. I think that is the key, and that's what would distinguish any kind of version of this that we would have in the UHP. It's got to be transparent and it's got to be responsible to and accountable to the UHP as a whole. And just as a personal note, just even calling it a PBM, I think just raises people's hackles because they have a reputation for not being transparent or having any kind of fiduciary responsibility to the people they're supposed to be serving. So we would have some sort of pharmacy sort of entity to negotiate prices or to sort out what we could make on our own or what we would purchase from where. But I think that even just that terminology is so loaded for people because of that experience. Gabe said, and not outsource this function beyond UHP. Oh yeah, maybe, I don't know. Yes, I'm not sure, but what I would say is like our role is just sort of outline some parameters for what we would want to see. And I think if we say, you know, that the pharmacy benefits need to be managed in a way that's accountable, transparent, responsive to the needs of the greater UHP plan, it certainly could be outsourced at some point. You know, there will be some outsourcing going on, but yeah, for pharmacy benefit, and I'm sure other aspects of UHP, but I'm just not sure what the details look like. And our role is to just set up parameters to understand how PBMs work and why they don't work, and then sort of set up some parameters for how we would want to set it up for a UHP. And then the decision about whether it's done within the structure of UHP or outsourced is like way beyond this board. I don't know how that would work.
I'd be just philosophically, I'd be very wary of outsourcing that function beyond Oregon because the potential for it to get co-opted just seems so strong.
Yeah. It's a lot of money to be made.
And we're kind of seeing that with the CCOs right now. That was like good intent outsourcing, right? And we are having some difficulties.
Mm-hmm. Mm-hmm. Yeah, that's we wouldn't need to make that decision, but we just need to understand, yeah, like what is our role.
Jamie?
I was just going to say there may be another pathway. I'm just trying to think, you know, multiple options. TRICARE lets companies bid for coverage of their members by regions. And so that's another option, is that we could ask a pharmacy benefit manager to bid for Oregon's universal health plan contract, but we would have the expectation of that transparency and accountability if we decided to do that. So there is maybe a third plan to give it totally away, to keep it totally in-house. There could be a competitive bidding strategy so that if they're not transparent or if they're not providing services, you know, we tell them we're going to look elsewhere.
Yeah, that's a really interesting idea. That's excellent. Yeah.
I will add, as a former military physician, that we did call TRICARE the best healthcare the lowest bidder could provide. So there is that.
Really funny. Oh.
All right, Chair, do you want to take a short break before give Lee a chance to drink some more water before the talking begins again?
Yeah, that sounds great. We're about there. So yeah, let's take a 10-minute break. It looks like 2:44. We can come back at 2:54 and finish up. Thank you.
If I could just ask real quick as a
Oh, sure.
point of, just like a point of order, the agenda says that there's 2 more votes. Is that correct? Are we voting on prescription drugs today?
Lee, were you ready for this to come to a vote today?
So the prescription drug stuff was related to the cost containment, so they've all been consolidated to the end of the cost containment deck.
Okay, so there's a vote at the end of that.
Yeah.
Yeah. So
Okay.
okay, yeah, so there'll be, after the cost containment part, we'll be voting on something regarding prescription drugs by itself, and then something overall on cost containment.
Okay, got it. Thank you.
The idea is we're gonna submit hopefully one, we could change this, but the idea is one straw proposal about cost containment in the UHP in general. And a portion of cost containment has to do with pharmaceuticals, but there are other things too. So we were thinking it would be one unified proposal, but that may change depending on how the conversation goes. Okay, let's take a quick break. 2:45, come back at 2:55, please. Okay, everyone, welcome back. So yeah, just to recap, I think Lee will go through a few more general slides on cost containment, and then if we're ready, we don't have to vote today, but if we feel ready, we could consider to put a couple of things forth to the board in terms of a cost containment proposal. As I mentioned at the start of the meeting, we do have one more meeting in March. And we could use that meeting to sort of refine, so if we have comments, we don't feel comfortable voting on it today, we could sort of make suggestions or refinements and bring it back next month as well. But let's get to the end of this and see where we are. So go ahead, Leah, I'll hand it back to you.
All right, thank you so much. And I will try to keep this spiffy, since I know we've had a lot of rich discussion, and I imagine we're going to have more at the end of this section as well. All right, so wanted to begin by just doing a really quick overview of what are considered traditional cost control strategies, these various 4. And one thing that they all have in common, these are really centered on individuals. So these are all about getting individuals to spend less on their healthcare. First and foremost, we have patient cost sharing. This covers a whole array of different cost sharing arrangements, co-payments where it's a fixed amount, deductibles where you have to meet a minimum out of pocket, and co-insurance where you pay a percentage of costs. So there's a lot of different ways that patient cost sharing is done. It's often a mix of them, even across the same plan. Now, what countless studies have found is that patient cost sharing does have an impact, yes, but it's not necessarily one that we should be particularly proud of. We find that the lower income consumers are those that are most likely to adjust their consumption of healthcare services. One really key example, when the Affordable Care Act required that all preventative services have no cost sharing, preventative services went up, and that's something that we should want. So, it's a little bit concerning that we find that people sort of self-ration care when they are subject to cost sharing, and that in particular, the population most susceptible to this is the population that probably needs it the most. Another very common method is prior authorization. This is a process where you need pre-approval to qualify for coverage of a specific service or perhaps a prescription drug treatment. This is seen as a tool to reduce healthcare costs by ensuring that the service is medically necessary as well as cost effective. Notably, prior authorization has a lot of critics, in particular physicians. The American Medical Society really despises prior authorization, citing in its annual survey administrative burden on providers just in terms of having to fill out the paperwork and the back and forth with payers, as well as care delays that can impact patient outcomes. They have some really compelling stuff related to that. So prior authorization, a tool, but one that is heavily criticized. Now, I think it is also worth noting we are potentially at something of a turning point related to prior authorization when it comes to both artificial intelligence and as we're considering within a single payer system. One of the many criticisms of prior auth is that every single payer has a different way of doing it. They require different information, and that creates a lot of challenges, a lot of confusion by clinical staff to understand what do they need for this payer versus what do they need for that payer. Under a single payer system, or at least more consolidated, less fragmented system, we would see fewer kind of in the variability there. There could be, one or certainly less systems. And then also we are seeing that there's some really significant benefits to having some of these electronic and AI-assisted prior authorization systems. So potentially some hope. Step therapy is another process that health plans often use to try to ensure that a patient has essentially tried all of the lower cost options before moving on to what is, the most expensive option, but what can also often be for some patients the only effective option. This is something that we see in prescription drugs where they'll start folks on a generic, for instance, and then try a different generic and then eventually move them up to what is a more costly brand name drug. We also see it a lot just in terms of different therapeutic treatments of wanting to try what is the low intervention before getting to the really high intervention costs. Again, like prior authorization, this has a lot of critics, and I think even more critically, it can really delay treatment to the point that patients might experience some irreversible outcomes, which is really pretty profoundly devastating, I think. And it is also frequently criticized by clinicians that these insurer steps are really based around how much money it costs the insurer, and they're not necessarily aligned with evidence-based guidelines. Tiered pricing, this is one that we see a whole lot in prescription drugs, where there is essentially tying back to that cost sharing, differential cost sharing related to the tier of a procedure or a pharmaceutical. So another way of really trying to hold patients accountable, but as that prior research has already shown us, that doesn't necessarily impact the patients that we want to be targeting with these. There is, of course, evidence that tiers does increase spending. It does improve uptake of generic and what are considered the preferred cost-effective treatment alternatives. For some medical procedures, such as a colonoscopy, it's found to be quite useful, something that is generally fairly low risk and does encourage folks to seek out lower cost providers and reduce that overall average cost per procedure. But it does place a lot of accountability on the patient to really understand pricing, something that many healthcare consumers are just not able to do because it is a complicated system, because they have busy lives, etc. So, this can also be a bit of a hit or miss strategy. So in sum, when we're looking at these traditional or individual level approaches, it's not awesome, really. The cost sharing, we know, doesn't really work in terms of producing great health outcomes. Prior authorization can, but again, there are some very real administrative and timeliness trade-offs that currently happen, and there could be some solutions to that, but as it currently exists, it does have some trade-offs associated with step therapy and tiers. Again, these have been shown to control costs, but I would say with even greater trade-offs with respect to who is being impacted and getting the right quality of care at the right time. So in general, these strategies are what have been used, and do they control costs? Yes, but do they do it in a way that really helps us create kind of a wellness aspect? Not necessarily. All right, so let's take a look at some modern cost control strategies. And what these really have in common is that we see that these are much more system level. So things like global budgeting, cost growth benchmarks, and really trying to strengthen primary care by including specific targets in that area. Oregon has 2 of these in place today, cost growth benchmark, as well as provisions in statute designed to strengthen the use of primary care. Global budgeting, I'm going to go through this super fast because you guys have already talked about this in your hospital payment. But this is essentially where you prospectively set a budget limit to some portion of the healthcare industry. Often used for hospitals, can be used for physicians. There are countries like Taiwan that almost have global budgets for various different sectors of their healthcare system. So this can be done in a lot of different ways. Global budgeting is most common in single payer healthcare systems. That really provides kind of the scale that allows it to be effective. And again, these can be done in all kinds of ways, impacting different segments of the industry, going across the whole industry, et cetera. You will have seen this slide, so the quick recap here is, yes, they have done studies on how global budgets compare to other types of, fee-for-service spending and healthcare, and they have found that it can reduce costs over time. So it does seem to be a viable system-level way of controlling costs. All right, our second strategy that really operates at a system level is having these cost growth benchmark programs. As you can see from the graphic, Oregon is one of a handful of states that have implemented this. And this is really used to track and monitor the growth of healthcare spending over time and establishing what is considered an acceptable upper limit. These are often based on different economic factors such as inflation or maybe a very specific inflation like a healthcare CPI, et cetera. And it's usually paired with data reporting, public oversight, and often some kind of enforcement. And I will say that Oregon has not had enforcement of this, but it did recently just pass its threshold starting this year, 2026. It is now able to hand out financial penalties for entities that exceed the target in 3 out of 5 years. So, there is some enforcement. It remains to be seen how that works out. I will say that while this is a really great tool for monitoring cost containment, it is very much what I would call a superficial tool. You're putting a cap on something and you're pushing it down. You're not actually addressing what's happening underneath. So it's a bit of a blunt instrument, but it is something that is out there. It is something that Oregon does have infrastructure and has been monitoring. The final one here is the strengthening primary care. So we all know that primary care is good for the healthcare system, that we want individuals to be accessing primary care, to be using it regularly, because that's going to reduce costs in just every manner downstream. It's going to reduce costs with respect to the number of chronic conditions, with respect to folks going into the emergency department because they let things escalate, and having essentially that early care coordination in order to manage things while it is lower cost instead of requiring them to go to the most expensive site of care. So Oregon is one of several states that has a primary care benchmark that is 12%. This committee, in its primary care proposal, actually voted to have that at 15%, which is really fantastic. That is California's target by 2034. So that puts us way at the top. When it comes to strengthening primary care, Oregon is definitely kind of leading the charge with this as a strategy. And I think that's wonderful. All right, so as we look at these strategies, we see these do tend to be a lot more effective than a lot of those individual-based strategies, which makes sense because when we're talking about a system, we're talking about broader impact, and we're really able to spread that out. In particular, global budgets and the strengthening primary care hold the most promise. The cost growth benchmark, you know, it's a tool, but it is rarely effective in and of itself because it is somewhat a blunt instrument, just kind of looking at things on the surface and not really getting underneath, not really providing maybe those incentives for the participants of the healthcare system to change things other than from kind of what's the bottom number that they come up with. All right, so Oregon does have some cost containment infrastructure in place, which is good news. We have an all-payer, all-claims reporting database. This is a comprehensive data set and is the primary source for a lot of these other things, such as the healthcare cost growth benchmark. This is how that measures price, utilization, and cost drivers. So it's been really helpful for the Oregon Health Policy Board. They've done a lot of really great analysis on this, really understanding, you know, what the different segments of the healthcare industry look like, how much they're increasing, which ones are increasing faster than others, and why they're increasing, and across market segments. So there is a lot of really just fantastic information to be had there. The healthcare cost growth benchmark, of course, this is what's really looking at that data and measuring it and publishing it. They have yet to do any enforcement, so it'll be really interesting to see, you know, what it looks like at the end of this year with respect to what organizations, if any, have they reached out to or have they assessed financial penalties on. So a little bit TBD on how much teeth that program is going to have. And then, of course, last time we talked about the Prescription Drug Affordability Board, last time meaning just before the break, so not all that long ago. Which is the state board that reviews those high cost and high impact drugs and tries to develop affordability strategies. Also does not have any real teeth to it. At this moment, it's all about the publishing. There has been some talk maybe of giving them the upper payment limit authority, but right now that also remains kind of in a TBD state. So just to summarize what we've kind of discussed over the course of this presentation, some of these strategies, leveraging the APAC for continuous cost monitoring, that's checked because Oregon's already doing that. So good job. Prioritizing the primary care. Again, Oregon is really leading the way with respect to this strategy. So I think that's one we can consider pretty well in hand. Certainly if this committee wanted to recommend something stronger, they could, but relative to peer states, Oregon is well ahead of them. And then these other ones that are in bold, these are ideas that are out there that this committee might want to consider raising or making the basis of a cost containment strategy. So utilizing global budgets within a single payer or limited payer system. And this doesn't have to necessarily mean hospital global budgets. It could mean all kinds of different global budgets. Really anything that you can envision is possible. Implementing additional enforcement mechanisms for exceeding the sustainable cost growth target. So this is if we wanted to lean into that mechanism, which is already in place, but does not necessarily have really strong enforcement at this time. And exploring administratively streamlined prior authorization, since that was one of the few traditional ones that has shown kind of more consistency as a cost containment tool and fewer negative outcomes, but again, does have very real administrative trade-offs as presently structured. And then I promised you we would come back to the pharmacy, so did want to add here, you know, a lot of our talk about pharmaceuticals is about cost containment. So a number of those strategies we raised at the end of that presentation. Ensuring programs are prioritizing the use of generics over brand names. So that goes to a lot of those transparency strategies, really trying to understand copay accumulator programs, as well as some of the drug manufacturer financial hardship programs, whether they are, I hate to use this term, but steering patients towards the use of brand name drugs. Also, oh, that's actually, I used it in my second sentence there. Mitigate manufacturer steering of patients towards brand name prescription drugs. So that one really gets to the financial assistance that is provided. Also curious how this committee would feel about, wanting to move forward with the PDAB having authority to implement upper payment limits, and then finally consolidating that state purchasing of pharmaceuticals. And then I put and DME because that seemed like a natural potential extension to add the durable medical equipment. And so here is everything. Obviously, this is a whole laundry list, so I would not expect there to be, a straight yes or no vote. But with that, Chair Belanca, I will turn this, what'll probably be a very rich discussion, over to you.
Yeah, thank you, Lee. Really appreciate all your background work on this. This is a bit of a complex topic, but a really important one. There are all kinds of reasons why we really need to consider cost containment. Even if nothing changed and there was never a universal health plan, healthcare costs, of course, are growing at a rate that's not sustainable. And so we're always thinking about cost containment, even in the current system. But then if we were to eventually get to a universal health plan, the risks of our healthcare costs exceeding our revenue are great. If people don't have copays or coinsurance, and we don't have sort of some safeguards or barriers built into the plan, I think we could get into hot water very quickly. Right now, if things get too expensive, people have choices. They can sometimes, not always, I acknowledge that, but they sometimes have choices. They could switch to a lower cost plan or choose a different strategy. But under the Universal Health Plan, we're kind of constraining people's choice. And so within the system, there need to be some sort of guardrails around escalating costs. There will be some induced utilization, as we heard from Milliman, and we need to think about what are the reasonable strategies. Chunwei has spoken really eloquently about global budgets at the board level and how Taiwan organizes it with different segments of with the universal plan, having a global budget, having not only a global budget for primary care, but maybe a global budget for specialty care and a global budget for hospitals and a global budget for behavioral health spend and a global budget for pharmaceuticals, right? And so you could have different segments of global budgets that you can't exceed. Lee's point is well taken, though they're kind of blunt and they're not very specific, but what it does encourage is sort of each individual region or each individual component of the system will have some downward pressure, like they know they can't exceed this budget amount. This is how much money we have to spend this year. And if we want to pay for this, then we can't pay for that, right? So those individual sort of shifting around decisions would be left up to people, different segments to decide. We wouldn't dictate, you can't have this, you can have this. There would be less of that and more of, well, you've got this much money for specialty care. So if there's this cool new procedure that, we want to be able to offer, then we've got to take away something else in order to get the budget to balance, right? So you would allow each segment to make those decisions instead of dictating them. So I'm really a fan of that. One thing that's not on here that I think is a really important cost containment strategy is universal fee schedule. The idea that right now, depending on who's paying, the cost is different. You get your knee replaced, and if it's OHP, it's one cost, and if it's a commercial payer, it's a different. And if it happens in the hospital, it's one cost, and if it happens in an ambulatory surgical center, it's a different cost. And so having a universal fee schedule about, and that would be inherent in a universal health plan, of course. Having a single fee schedule would be there. It's not explicitly called out, but I think that's also an important one on here. Yeah, those are my initial reactions to this. I'm interested to hear other people's initial reactions, or if you have questions on where this should go.
I think Peter was first.
Hi. I have several questions or points. So two of them are about the items on the screen right now. So you've got you mentioned briefly explore administratively streamline prior authorizations, perhaps by utilizing AI. And that's going to be a hard no. AI decreases available drinking water, it increases air pollution, it increases ambient temperature and global warming, and all of these things reduce population health. So we would be drastically reducing health in order to later down the pipeline make it easier for people to get the drugs that they need to mitigate the symptoms of the poor health that we have created by using AI. It's just incredibly inefficient. That's a hard no. The other one, just kind of more of a quick question. When you, so manufacturers steer patients toward brand name drugs, and it would be nice to mitigate that, agreed. But under, like, what teeth do we have? Like, how could we actually, like, do that? You know, like, how could we incentivize or disincentivize that to happen? So that's just an open question. And then the third, and perhaps the most kind of the longest or more interesting thing that I don't see on the list here is usually, at least for me, when I usually think of cost containment strategies, there's a very common one. There's a very long history of cost containment as further exploiting employees, reducing hours, reducing benefits, overtime without pay, good old wage theft. You know, that's a great way for companies to contain costs. And we need to disincentivize that as best we can. We need to protect workers in any of the private businesses that we're going to be that are going to be part of the universal health plan. How to do that is, you know, that's a very complicated thing. But the main one that I wanted to point out, and then that's it for my soapbox. Here in Portland, I'm in Portland, so we have a business tax where if the CEO earns more than 100 times the median worker's pay, if the ratio of CEO pay to median worker pay is greater than 100 to 1, they are taxed. They get an extra 10% tax. And I like an idea of that. I don't think it has to be those specific numbers and that specific thing, but that will do two things. So we reduce the people at the bottom end of the pay scale from getting further exploited as a cost containment measure. And at the same time, if that reduces the pay of the C-suite executives and the board, then that also is cost containment, and that is saving money so that that money can then be spent on actual healthcare and helping people to get better. So cost containment cannot involve further exploitation, is the end of my little speech. Thank you.
Yeah, thank you for that. That's really important stuff. I want to jump in and just on the prior authorization thing really quick. I think there are different ways to approach the problem that prior authorizations are trying to solve. They're trying to solve for this idea that people are seeking really expensive care when it's not quite needed, right? Or when there are less expensive options. It doesn't do a great job of doing it, but I think that's its intent, right? Is to avoid expensive care when there are less expensive options. So, you know, somebody has, you know, sore knee for 3 days and they come in asking for an MRI. Well, you know, there should be probably some steps in place before you get that MRI, right? And so there are ways to do that with, so forgive me, but I mean, I work for Kaiser. Kaiser doesn't have prior authorizations. They don't exist. But what we do have is standards of care. And we have, you know, clinicians who set up standards of care. And this is the point at which you should get an MRI with knee pain. This has happened, this has happened, this has happened. You've tried this, you've tried this. And if you've done all that, then it's appropriate to get an MRI. So it's not a prior authorization, but there are standards of care for all kinds of expensive things and steps that we are required to take before that. But then we don't have to sort of ask for any of that. So there are ways to do, like, you know, you make a whole bunch of things where there will be no cost sharing, right? And then in order to get to the more expensive procedures or the more elaborate steps, then there could be some things in place where you have to certify that you've met sort of these criteria to get there. You know, so prior authorizations are a really sticky subject. I think they are much easier dealt with under Universal Health Plan than they are currently, partly because you're not dealing with so many different players. But yeah, your point is really well taken about when we approach cost containment, we have to think about the implications of it. Yeah, who was next?
I think it was Jim. You're still muted.
As someone who's been in the employee benefits business my entire career, cost containment is our lifeblood, I guess you could say. But one of the things that I have learned working too long in this system is that because we are unable to really manage the costs within the system, we constantly put the patient in the middle. We put the patient in the middle by restricting networks, by demanding more money, by prior authorizations. And when I criticize some of these efforts for being constrained by status quo thinking, that's an example. I'm glad to hear Helen really talk about what Kaiser is doing, because ultimately, if you have consistent standards of care, you really shouldn't need prior authorization.
Right. That's
and right. I had a personal experience not too long ago. I went to my cardiologist and he told me I needed valve replacement surgery. And it was a bad time in my life. My wife was about ready to die, and I did not want to hear that. Fortunately, I had a friend who was a cardiologist, retired cardiologist at Cleveland Clinic, and he wrote a letter to my doctor saying basically that Jim does not meet Cleveland Clinic's standards of care for needing open heart surgery. Now, I don't know who would have stopped that surgery if that hadn't happened. But, you know, I don't know how many people are familiar with the example of Reading Hospital in California. There was some sort of racket going between the hospital, the cardiologist, and the cardiac surgeons. And they were just operating on a lot of people that did not need surgery until all the fines and court settlements were settled. It was costing almost $1 billion for mistreatment. So there needs to be standards of care. There absolutely needs to be standards of care. But prior authorization is not the answer.
Jim, thank you so much for saying that too. You said something, and Lee said it at the very beginning of this conversation also, and I really want to underscore it, that traditionally we think of cost containment as constraining the patient in some way, or the person seeking care in some way. And instead, we've got to be thinking of system solutions that put the burden on the system to do a better job of being efficient and effective, and stop putting the burden on patients and making patients wait and delay. But yes, standards of care is right up there, as well as some other sort of system strategy, and just being aware of the burden we're putting on individual people that are trying to get their care needs met.
Oh, Chenwei, I believe you were next.
Thank you. I have three comments, and two of them are actually related. First, about the global budget. I think if we decided we want to have hospital sector in the global budget, and on top of that, we also want to have a target of 15% of primary care. So we already have a de facto two-set of global budget. And then even without explicitly designating other sector, we have a de facto global budget for all other sectors. And this is why from the beginning, I have been a strong advocate that if we want to have a global budget for one sector, we should have global budget for all sectors. Also, on top of that, one important function of global budget for cost control, like Taiwan did for nearly 2 decades, is also have a total global budget together with a growth limit. And that's somewhere in the near future. I think the legislator have to deal with that. Taiwan set the annual global growth of the global budget, total global budget at 4%. And so that's something to be considered. So with the total global budget, we can also couple that with the cap of annual growth rate. And then the second issue related to prior authorization, Helen mentioned about center of care. And what Taiwan did is for most procedures, they have built into explicit indications. And therefore, they still implement prior authorization, but that prior authorization in the case of Taiwan is an exception rather than the norm. That when there are rare cases that might require prior authorization. Otherwise, as a norm, there's no prior authorization with some exceptions. But related with that issue is one important measure we seem to left out is how do we prevent fraud? For example, Medicare has done that for nearly more than half centuries. And what Taiwan did is what they call a random audit and target audit. It's a kind of utilization review. It's post procedures, but they're not doing that universally. They're doing that in general, random, as a kind of deterrence. For each organization, they just randomly, periodically selected a few cases to do post-procedure review. But they also have targeted review. When certain procedure, they have the algorithm for raising flag. That particular claim has a flag, then they perform that review. So again, this is just example, but we need to also to think about a measure to prevent and deter fraud, because based on the Medicare experience, there's a lot of fraud existed that also a measure of cost sharing.
Thank you for bringing that up, John Ray. That's really important. Yeah. Did you have something else? Sorry, I didn't mean to cut you off.
No, the two issues are related. How to prevent fraud, such as audit or post-procedure review, is coupled with the issue of indication and pre-authorization. So these are related issues.
All right, Julianne?
Thank you. You guys are now in my wheelhouse. So I've been doing insurance now for over 20 years, and this is all the things that we talk about day in and day out. And I think that there's a portion of every single one of the strategies that you brought up that actually can play a small integral part in that cost containment. But what we haven't talked about here is the PBM and making sure that it is transparent and that the formulary is focused and driven to the lower cost drugs, that the costs are posted, and that any type of rebates actually go back into the system, and that there's incentive there to use the right drug at the right time at the right place. And having a PBM that's fully transparent. Like, that's the one thing. And I'll say, Helen, I love the fact that you are from Kaiser, and that a lot of what that was discussed in this is truly Kaiser-esque, because they look at all of these. Where I'm looking at in the utilization global budgets, that's super difficult in respect to if you're looking at Eastern Oregon versus Portland, Oregon. You've got different costs for care. And so the global budgets are going to really be difficult to manage in such a rural state. So again, it's going to have to come down to transparency and costs, what those true costs are, having oversight and budgeting and making the consumer wise. Not just show up and say, I'll do whatever the doctor says. Just like James said, Jim, you had you're supposed to have surgery. If you didn't want the surgery, you don't have to have the surgery. You're not required to have it. Like, we have to make everyone a consumer. I'm going to go back to the last portion of this, which is if we can integrate both the payer, well, not the payer, the patient and the provider, and have a third-party auditor that's overseeing that, I think a lot of these are going to come forward and like popcorn up to say that there's a portion of every one of your strategies that would be successful.
Thank you, Julianne. And it's so great to know that this is your area of expertise. I'm sensing a homework group forming, but I don't want to put that on anyone involuntarily, but it seems like there's enough here that we might want a small group to kind of formulate a proposal for cost containment. But let's take any further questions. I know there's a couple more people with their hands up.
Angela was next, and then Betsy.
Okay, thank you. Yes, I really appreciate and agree with the point around taking the patients out of the middle. And I think, one area though where cost sharing sends an important signal is the ER. So would the PCPCH model kind of address that through incentives? So you're not having patients worry about that, but you're incentivizing case management or other so that patients aren't going to the ER, or like how. I think there's other ways that you could structure that incentive, right? So that the patient isn't there. And then at what level is the global budget? Is it the regional entity or is it by services? There is some advantages by having it regional and how you're thinking about it versus services. But yeah, just that was more of a question.
Yeah, it's a sticky question. Yeah, it's a sticky question. We've considered both, but it seems administratively simpler to keep everything sort of at the higher level, but have global budgets by sector. But we haven't really, to be honest, dove into that issue at the board level. But yeah, it's important to keep that in mind.
I mean, apologies for jumping in, but I would say that definitely that the regional areas would not bear risk. I mean, I think that's been really determined.
That's true. Yeah,
so in terms of a regional global budget, that's not, that was sort of taken out of the commission or out of the plan, but certainly other sectors is still in play.
Yeah, so thank you, Mimi. I appreciate that. Yeah, so definitely the regions don't bear risk, but like it would be good for a region to know sort of their rough targeted, amount that they have for various services. They wouldn't be held to it in terms of risk. They wouldn't take downside or upside risk, but like thinking of costs regionally might come into the equation at some point without a risk bearing component to it.
And just to add, I know for us, we have a total cost of care measure through our ACO, and that does force us to be like, okay, more CHWs, more nurses, right? Things like that. We have that financial incentive, right, around that as a way to reach out to folks who are the high utilizers. We're thinking about a totally different planet and world, right? So it's, again, to Jim's point, right, to not use the current structure.
Yeah.
Betsy, I think you were next.
Just a comment and sort of a reflection of this conversation, and I so appreciate the earnestness with which everyone is trying to come up with our best shot in terms of our ideas. But I think it's also important to remember that we probably won't get this 100% right. And that this won't be the first, I'm hung up on the cost growth target thing in my brain, right? Because I worry that even if primary care clinics are never penalized for it, they still have to dance the dance and prove that it's reasonable, blah, blah, blah. So I want to say something like, we assume that some of these mechanisms are going to be better than the best one that exists right now, right? So to Peter's point about AI, totally understand your point about the energy consumption and hallucination. And I think there's lots of ways we could improve prior authorization without taking that step yet. And maybe someday that'll be okay. You know, we will have converted our energy grid to sustainable sources enough. Anyway, so I won't go on, but just to say, we're trying to forecast a whole lot of stuff, as James was saying, that, you know, that it's never been done before in the States. And I appreciate everyone trying so hard to figure out what the right stuff is.
Yeah, thanks, Betsy. I want to reflect back really quickly to our quality strategy, which I think Mimi did an excellent job of pulling together. We might do something similar in terms of cost containment, where there's like strategies and principles and sort of a framework for cost containment without, you know, to the extent we want to endorse specific strategies and saying we ought to do this, you know, we can certainly do that. But to the extent we just have sort of concepts and principles and a framework, we could also outline that as well, which gets to your point, Betsy, because like this is going to have to be worked out in a whole lot more detail than we would have time to work out.
Jump in. I really appreciate that, Betsy. Things are going to change. New technologies are going to come. And we've talked a bit about a construct that is going to be informative, something to the HERC or something like the National Institute of Clinical Excellence in the UK or other bodies that are going to be able to weigh in and create those standards of care, create that evidence-based background that is going to empower the work to make sure that these tough decisions. Fundamentally, what this comes down to, if we look at every single healthcare system across the world, is there are different tools that are in place. There's a limited availability of this commodity of healthcare, and we can't have everything. And we need to figure out how we make sure it's equitably distributed and an efficient allocation of care. And so some of these have been tools that have set barriers and limitations to delivery of healthcare. Some of these have been great, right? Some of us, it kills me even to look at the word prior authorization. I'm vomiting in my mouth as I look at that thing. But the basic honest truth is that there are some different health systems delivery where they're not writing the correct prescriptions. They're not referring the correct thing for a procedure. There needs to be a checks and balance, and that's really kind of what we can put a different label on as a prior auth. But there are some things that we need to be real about what we can and what we can't have and what we can afford. And I know we don't want to talk about copays. And I think we should go with what evidence is for across the many different universal healthcare systems that have implemented small copays on medications and different interventions. And a lot of them have actually retracted that. So I think in our own evidence, the RAND, study and everything, thinking about the different populations have different impacts to all of these levers that we're pulling. And I think that Betsy outlined it very well, is that we're not going to have the complete answer, but we should have some constructs. I would say the good majority of these, as far as global budgets, regional global budgets, empowering primary care, really one of the greatest levers that a universal healthcare system is controlling price. And that's really fundamentally what a healthcare system is going to do, and then create efficiency on the administrative side. So I think that these, when we get into these, are very tricky to talk about. I think some of these have merit, some of these obviously we're not going to all agree on. But I think that the framing of this conversation, but I'll just wrap it up, that I think that setting an entity with the public corporation that can continue to weigh in on these conversations, again, fundamentally based and predicated on evidence-based interventions that are cost-effective too. So.
One of the things that Milliman brought up in terms of cost containment was a tiered pricing for pharmaceuticals. Lee, is that considered part of one of these strategies, or should that be pulled out as a separate one?
That can be added. I mentioned that earlier on. I'm trying to add
Yeah.
to the list as people. So if you'd like me to
Thank
include
you.
it, I can.
Yeah, so the idea that, there'd be this enormous formulary of predominantly generic drugs that has no cost to it, for people on the universal health plan. And then if you wanted a brand name, I think they recommended something like a $5 copay for the brand name over the generic. And then for some of the specialty drugs, like the level 3 drugs, the certain cancer drugs or gene therapy, the many thousands of dollars a month type drugs, there'd be like $100 copay, so you could have 3 tiers within pharmaceuticals. I know that instituting cost payment, like just having that as a thing, introduces, that's the word, right? Introduces a whole new administrative structure. So collecting those payments, will have some costs to it, right? But I think the brand name and generic, there's got to be a cost to brand name drugs, right? To get people to use the generics. So I don't know. That's something that we could consider as well. That I would just put that out there for consideration.
Absolutely. Jim?
So one of the things that I wanted to comment is this item here, mitigate manufacturer steering of patients towards brand name prescription drugs. I assume you're talking about couponing. I missed the discussion on that. So, and
yes,
Medicare outlaws it, and why it's permitted in the employer market baffles me. I had rounds and rounds with our PBMs about that. And I don't see why we couldn't outlaw it in Oregon. Medicare views it as a kickback, or I don't know exactly how they view it, but it's not permitted under Medicare. And I think that item should be either reworded or removed from the list.
Okay. It looks like Chunwei still has his hand up, and then I want to kind of steer us toward wrapping up. Chunwei, did you want to add something?
Yes, this is just a comment to what we're just discussing now about potential copay for tiered prescription drugs. Most countries with universal health care has developed a full formulary. And the formulary is not just for reference. All prescription drugs within the formulary are covered. Any drug not in the formulary are not covered, meaning patient want to use any drug outside the formulary, usually they pay the full price, not just copay, full price.
Interesting.
And also, I also have a comment about brand name drugs. There are modification about limitation on brand name drugs. For example, when certain category of drugs, there's only brand name available, then many countries will cover that. The preference for generic is whenever generic is available for the same category of drug.
Right. Thank you. That's really interesting. Okay, what I was wondering if we could do in the little time we have remaining is there's a bunch of strategies already listed here for consideration. These are not necessarily everything that we're going to include, but I'm wondering if anybody has other strategies that aren't on here that you want to make sure that we consider. And then maybe we do a little homework before the March meeting to sort of put together a proposal. If there are folks in this group who want to just spend a little bit more time and think through, which on these lists we should include, which we shouldn't. And again, it doesn't have to be worked out in detail, just kind of a basic framework or structure of the primary cost containment strategies. Maybe we could have 2 or 3 people sort of gather to do that. And then bring this back as a cost containment proposal in March. In March, we're also going to be talking about workforce. And Mimi, correct me if I'm wrong, but I think those are our only 2 topics for March.
So far, yeah.
Okay. Yeah. So I think that's reasonable. So first, let me just open it up. If anybody has strategies for cost containment that they'd like to see on this list that isn't already here, let's get those on here. Anybody?
Jamie has her hand up.
Okay.
I just made a comment in the chat that we might want to call out specialty drugs specifically, because it sounds to me like an area that I don't have a lot of expertise in, but that's the majority of the cost driving in
Yes. Yes.
pharmaceuticals. So maybe calling out, if we don't have the expertise within our group, to call out that that's a gap and that more study could be done specifically around specialty drugs to find cost saving strategies there.
Yeah, I really like that. I appreciate that. Yeah, so some sort of separate mechanism by which specialty drugs are paid for. And I don't know what that would be, but like even separate from tiered pricing, like those have to be accessed in a certain way. Yeah, I think that's really a good one. Thank you. Anyone else?
Yeah. Implicit in a lot of these suggestions is the notion of over-treatment or unnecessary care.
Yeah.
And I just sort of like to call that out in some manner, fashion, or form. It's implicit in prior authorization. It's implicit in some of these notions of cost sharing and whatnot. And yeah, that's.
Yeah, I agree. There is an issue with it, though, as me and the others have been practicing medicine, like unnecessary care. Like there's a big portion of folks who are not getting the care they need. There's another portion of folks who are getting way too much care, right?
I actually saw a statistic one time that said that the recommended that people over a certain age are recommended for colonoscopies, and people with insurance get more colonoscopies than they need. Whereas
Exactly.
people without insurance don't get enough colonoscopies.
Exactly. That's a case in point. Exactly right. So we got to address it from both ends. But yeah, no, your point is well taken, and just being considerate about that without denying people needed care for sure, or unnecessarily delaying needed care. Okay, any other strategies? Because we're getting close to wrapping this up. If you have any, sorry, are there any hands up?
Yes, I think
Okay.
And Jamie.
My suggestion is what I already mentioned earlier.
Okay.
This can be incorporated to a new wording, new language on line item number 3, explore administrative streamline. It's about how we prevent fraud.
Yeah. Oh, yeah. Make sure, let's get that on there explicitly. I think that's really important.
So if I may, Chunwei, you said sort of the two things you were thinking of, specifically post-procedure reviews and also audits.
We can find a better language for what might be appropriate. Mainly the purpose is preventing fraud.
Yeah.
For example, the one of the big event in the Medicare was that providers continue to send in claim on behalf of their people.
Right.
Call out, no care for the dead.
Right. I think we can agree on that. And then Jamie?
I just said at the end that I think also implicit in reducing cost is a primary care workforce that prioritizes family medicine. Because as a specialty, family medicine decreases unneeded procedures by 30%, it drops costs by 30%. You have a 30% less chance of dying if you have a family medicine as your primary care doctor. So like that in itself, I think should be called out as a cost containment strategy that requires upfront investment.
Yes. Thank you. Yes, we'll incorporate that somehow. And I saw the comment about the Choosing Wisely initiative, which I love, and that goes along with our sort of standards of care idea of when tests are appropriate and when they're not. Awesome. Okay, so if you have other suggestions, did I miss anybody?
I was just going to add in, this happens when you have the public health officer is that we haven't really talked about population health level initiatives, but just know that will be coming your way as well.
Okay, great.
Correct the typing. It's not prioritize family care. It's prioritize family medicine pipeline.
Mhm. So, there's going to be some work done on this before our March meeting and kind of roughly sketch out a proposal for the committee to consider in March. Is there anyone who would like to volunteer to work on that in the interim and do a little work on the side on this?
Specifically on what?
On the cost containment strategy, what it should
Yeah,
look like, what it should include.
I'll volunteer.
Great, thanks, Jim. Anyone else?
Hopefully not by myself.
I would also say people are welcome. If you have your favorite, send an email. You just send it to myself or Isabel or Lee. This is what I want you to include this. That's good enough. You all have a lot of work you're doing.
Yeah,
So.
yeah, that's true. Yeah, if you just want to like submit comments to Mimi, you could just write up an email and say, you know, I think it should be this, not this, or whatever, and submit that to Mimi. Yes, that's totally great too, if you don't want to. But yeah, if we wanted to get together and talk through some of these, if anybody wants to join that conversation, we'd be open to having you join that conversation.
I'll jump in.
Who was that? I missed it.
That was Julianne. Thank you.
Awesome, Julianne. Excellent. Thank you. Cool. Anyone else? I'm sorry. I apologize. I can't always see hands, so I don't know if somebody else has their hand.
Nope, sorry. I would have told you. Sorry, no one else.
Okay, great. Awesome. Okay, so let's just spend a couple minutes on public comment. Isabel, is there someone signed up for oral public comment?
Not today.
Okay, we had a couple of pieces of written comment that I want to draw the committee's attention to. Most of it's posted on the site. There's one piece that isn't posted. So Tom Sinsick wrote to the committee. He and Valdez Bravo wrote an opinion piece to the Lund report, and he submitted the full article as his public comment to this committee. I encourage you all to read that. Forgive my pronunciation, Pia Quimson Guevara submitted a comment about wondering how reimbursement would work. She works in the behavioral health realm and wondered about that, had some questions for us. Maitri Lamb wrote in to just express general support for our work. Amy Fellows, one of our board members, provided testimony to this committee with concern that we might be completely integrating behavioral health into primary care, and that was not an option that would work for everyone. I can touch base with her on that. I don't think that's what we're recommending, but more along the funding streams. And then Todd Ferris is the one that is not included on the website. He wrote to the committee asking us to reconsider our contract with Milliman because he doesn't believe their expenditures accurately capture the expenditures under our universal health plan, that it's really promoting the status quo. And we talked about that a little bit at the beginning of this meeting. But his testimony is excellent. Isabel, how would people read that? Is that going to be?
I can send it to the committee today and it will be posted on the website, just some technical slowness.
Okay, yeah, so you can either check back to the website in a little bit or yeah, but it's really worth it. And then we'll get out an official copy of the behavioral health proposal to everyone. Is that right? The written copy before the board meeting, and if people have comments on that, they can email us back on that. And any other reflections or feedback? We have one more meeting in addition to the workforce and the cost containment strategy. Do any committee members have things that you want to make sure we circle back on and touch base on or cover at that meeting?
Can I ask Isabel to send the updated final list of those strategies that we were being editing?
Yes, can do.
I just want to second Amy Fellows's public comment. I agree with everything that she wrote in there. I think everyone, it would be nice for everyone here to read that. It's page 13. It's the last one. It's only one page. I also agree that I don't think that I think that we're not going to do the bad things that she's hoping that we're not going to do.
Yeah.
I didn't say that well, but those are all very worthwhile concerns to read. And I second all of it.
Yes, absolutely. she wanted to make sure there's a variety of delivery mechanisms for behavioral health and that it wasn't purely behavioral health integrated into a primary care setting. And so, yes, I agree. I think her concern, we can address her concerns, and yeah, absolutely. Cool. Any other thoughts for our last meeting before we wrap up? Awesome. I really appreciate everyone's attendance and your very thoughtful participation today. We so value this committee and all of your expertise. Thank you so much for coming today, and this adjourns the meeting. We'll see you in March.
Thank you.